Emerging Treatment Practices for Veterans Experiencing Combat-Related Post-Traumatic Stress Disorder, presented by Lakita Sutton. Before we start the presentation, I'd like to first introduce an icebreaker. My name is Lakita Sutton. I'm a licensed clinical social worker and a licensed clinical addiction specialist. I've been a licensed clinical social worker now for almost 10 years. I've also been a licensed clinical addiction specialist for 9 years. I am currently licensed in North Carolina, South Carolina, Georgia, and also Virginia. On the next slide, I'd like for you to examine the picture, and I also like you to think about what comes to your mind when you look at it. Notice the words on the picture and how it relates to the idea of PTSD, particularly when it comes to working with veterans involved in combat. PTSD. I may no longer wear a uniform, but I'm still at war. What does this picture mean to you? What do you think about when it comes to trauma and veterans? Do you agree with this slogan, I may no longer wear a uniform, but I'm still at war? This picture means to me that even though the event of war or the event of combat may have already come and gone, it still has a lasting effect on individuals, particularly veterans and their families. So therefore, this makes sense. The individual could still be at war. They could still be re-experiencing the trauma. And this is what really drives the whole idea of post-traumatic stress disorder, particularly combat-related post-traumatic stress disorder. Purpose of the presentation. Combat-related PTSD is often experienced by military veterans. This type of trauma occurs more often than PTSD experienced by civilian population. PTSD experienced by veterans involved in combat does not look the same in relation to the isolated traumatic and avoided incidents faced by general population. What is the problem? Due to public and private stigma about mental health, less than half of veterans who are experiencing combat-related PTSD symptoms seek out help. These veterans also have psychosocial needs that increase their worries about feeling they are inadequate or less than able to remain involved in carrying out service duties during and after war. Other problems. Traditional therapeutic approaches such as evidence-based treatments, known as psychotherapies or talk therapy, for example, cognitive behavioral therapy, seems to be just not enough these days. Therefore, professionals, counselors need training and access to empirical practices that are more emerging and that can also serve as helping the veterans in combating and identify, as well as gain control, not just over their physical conditions or their psychosocial conditions, but also their physiological arousals that happen within their minds. What is the solution? Due to the lack of effectiveness in addressing needs of veterans, particularly those involved in war once they return, there's a great need for which further reinforces the need for emerging and evidence-based practices that will have a lasting effect and also engage the veterans. Objectives of this presentation. We basically, in this presentation, will evaluate and define psychosocial conditions and psychological symptoms associated with PTSD and combat-related PTSD. We will also outline an eclectic integrative whole health model approach that I currently use in reaching military veterans involved in war who experience combat-related PTSD based on empathy, compassion, care, and hope. Other objectives. We will review specifically innovative and integrative empirical practices such as neurofeedback and also art therapy when it comes to addressing and treating combat-related PTSD. We will also talk about briefly and discuss current practices that I currently implement that relate to treating combat-related PTSD based on what I call the graph model approach, to ensure whole health needs of individuals are met in conjunction with traditional-based psychotherapy and emerging treatment approaches. We will also apply the Christian worldview aspects of using empirical practices for combat-related PTSD. Post-traumatic stress disorder. Basically, post-traumatic stress disorder is a result of overly being exposed to or witnessing life-threatening events resulting in an intense feeling of fear, horror, or helplessness. Now, everybody at some point will experience trauma. However, not everybody will experience post-traumatic stress disorder. In order to be a person that has experienced post-traumatic stress disorder, there is a Diagnostic Statistical Manual, or the DSM, that suggests certain symptoms or certain behaviors to look for when you are diagnosing or when you're talking about the idea of someone having PTSD. Some of these symptoms include a presence of intrusion symptoms, including recurrent and distressing memories or flashbacks, efforts to avoid any stimuli associated with the event, negative changes in thoughts and mood, including suppression of memories associated with the event, cognitive distortions and exaggeration of negative beliefs, withdrawal, and even detachment behaviors. And also, other symptoms include changes in arousal and reactivity, including hypervigilance, recklessness, and increased irritability and anger. The individual also may feel irritable and experience extreme guilt or worry. Combat-related PTSD. Combat-related PTSD relates to trauma in those involved in military. It is suggested 12% and 30% of warfighters returning from deployment in Operation Enduring Freedom and Operation Iraqi Freedom, for example, experienced combat-related PTSD. However, due to negative consequences associated with combat-related PTSD, less than half of warfighters report symptoms. And this may be because they fear. They fear that they might be socially isolated from their duties, or they might be ostracized because they report a mental health need, which is something that continues to be a problem within military. However, combat-related PTSD occurs usually after exposure to a variety of traumas, such as rape, abuse, natural disasters, racism, and physical assault. However, when we talk about combat-related PTSD, it develops from a different type of experience that includes exposure to war-related events, interactions or trainings, and even psychological preparation for war. So these are things that heighten the individual's ability to remain calm, and it also heightens the person's ability to also, while remaining calm, is also a result of numbing themselves. Combat-related PTSD, people involved in combat are taught to operate, as I stated, remaining calm by numbing themselves with a heightened level of physiological arousal to function in combat. When veterans in combat return home, they're never taught how to relax or how to be present again. Instead, they're just pushed back into their environment that they came from before they went to war. And I guess they're expected to function normally without any transition, without any step down, without any support in learning how to reacclimate themselves to home. This involves, as a result, complexity of PTSD. When we talk about combat-related PTSD, what that entails, it involves a neurological reaction, a physiological arousal, and an emotional response. In the face of danger, when we're talking about combat-related PTSD, neurological pathways in one's brain signal the release of stress hormones, including stress hormone that causes one to fight, freeze, or flight, which is found in the sympathetic nervous system. When an individual is constantly fighting in a war or constantly training for war, they often experience traumatized states for long periods of time, or stress after stress after stress. Over time, because of the stress after stress after stress associated with war, they in turn create this automatic reflex, or always on the edge, always on the defense, always ready for war. always heightened in their amygdala within their brain. And this in turn causes the person, particularly the combat person that was in war, to always be operating from the sympathetic nervous system side instead of the parasympathetic nervous system side, which the parasympathetic is about being calm, relaxed, and facing by digesting the situation. More complexity. Because of the complexity of combat-related PTSD, this in turn creates memories leading to re-experiencing and visual recollection and sensory impressions of the traumatic event, particularly when it comes to war. As a result, the vet might in turn have nightmares, flashbacks, because this person is unable to place the memories in appropriate sequence in life events, particularly when they come back to their home. Symptoms of combat-related PTSD. Preparing for combat could increase the chances of developing PTSD for vets before fighting in war. It could cause triggers from a neurological reaction, physiological arousal, and emotional withdrawal that grows and stops the ability to show resilience and recover after one engages progress, and potentially inhibit recovery after deployment. So basically, what happens is because the person, as I said before, has an elevated sense of operating from the sympathetic nervous system, the fight, flight, or freeze perspective, they're always on the edge. They're always on the defense. They're always ready for the worst. And this is something that constantly keeps the brain under stress, constantly keeps the heart under stress, constantly keeps the body under stress, and constantly keeps the person revisiting the trauma. Symptoms that relate also to combat-related PTSD could occur when veterans are not retrained to decrease the heightened state of physiological arousal, meaning if they don't get time to come back and transition from war zone to home, this can create more stress, and that more stress creates more traumatic experiences. As I said, this creates trauma because responses they are used to being involved in when at war, such as fighting and protecting, that same activity doesn't work when you're coming back home. However, the brain activity is not healthy and is also not under normal conditions anymore because of the fact the person is always in that sense of war zone or in that traumatic zone. They're not calm. They're not able to just be present to the moment, and they continue to experience and treat everything as if they are in a war, even if they're no longer in that particular environment. Other symptoms. Those involved in combat or war fighters are trained to also suppress any emotions. So not only are people operating from a heightened level of stress or heightened level of being on the edge, they also are taught to emotionally suppress or numb themselves. Feeling suppressed by military veterans may hinder their ability to make progress and participate in treatment. It also can prevent them from transitioning in a way that's healthy. Symptoms of combat-related PTSD also include people being in the military taught to quickly assess for any risks or dangers in war zone. Like the first thing they might automatically think is the worst, or automatic thoughts might be distorted with, "Oh my goodness, this is related to war." However, warfighters are required to embrace this mentality, particularly when they're about to go and be deployed, and to further function in this state. So always on the edge, always ready for war. This is what veterans are taught before they go to war. However, when they are back at home, as I've said before, they are not taught to transition back to that state of operating more from a parasympathetic nervous system perspective. Other symptoms. Warfighters or people involved in combat, they're trained to embrace the absolute. They think before in a combated experience because their lives are basically dependent on others as well as knowing that people are dependent on them. Other symptoms, emotional numbing, avoidance. Needed to be successful on a battlefield, They bring that same mentality when they return back home after war. Warfighters or people in combat are trained to emotionally detach from situations at hand prior to combat, which also sounds like a lot close to the symptoms of PTSD. The severity of combat related to PTSD, without appropriate training to learn how to experience and make sense of emotions, make meaning of the emotions, make meaning of their traumatic experiences, the veteran will suppress as necessary in time of war or just like they would in war. And so when they come home, they have maladaptive method of coping, therefore increasing their vulnerability to comorbidity relating to substance abuse, depression, suicidal ideations, and further impairing recovery. Psychosocial barriers of combat-related PTSD. Warfighters with combat-related PTSD experience circumstances unique to the military population that prevents them from asking for help and care to deal with traumatic experiences. Basically, those in military, they are groomed in the culture of the military to not ask for help or to be the one to protect and serve. So therefore, a person may internalize and think, oh, I can't ask for help because I'm in the military, or I can't ask for help because I just came back from war. However, the main psychosocial barriers included that the person in military that comes back from war or has engaged in combat, they deal with stigmas, personal concerns, and situational barriers associated with the mental health diagnosis of combat-related PTSD. Other psychosocial barriers. There are stigmas in the military about mental health, and not just in the military, but also in the community. Veterans are concerned with outside perceptions of them and also personal internal conflicts they may acquire as a result of dealing with the idea of having combat-related PTSD. Veterans or warfighters are built to withstand trauma on a battlefield without requiring assistance starting from combat training. This in turn is something they internalize, and so when they return home, they constantly are at battle at war with thinking that they have to be strong all the time and take care of everybody. So once again, this causes conflict and more trauma. People in the military are trained to have an attitude of strength. Warfighters with combat-related PTSD turn away from treatment because they worry about how members of their unit will perceive them as being weak or vulnerable. They also struggle with self-esteem issues, often feeling inferior and embarrassed about asking for help, believing they are the cause of their problem, or that seeking help validates the thought that a problem exists. However, psychophysiological supports to make a difference are key. Encouraging connections are key. Emergent practices are key. And it requires a person-centered treatment and evidence-based practice approach, particularly when working with vets that have combat-related PTSD. Innovative and integrative empirical practices for combat-related PTSD. Based on the eclectic model that I currently use right now, I use CBT, narrative therapy, motivational interviewing. Currently, I'm in the process of gaining more training in neurofeedback, which is an emerging practice that would work very well and has been proven to work very well with those that have combat-related PTSD. Also, another emerging practice is the use of art therapy with vets who have been involved in combat. An integrative model of care for combat-related PTSD, as I said in the previous slide, I'm currently using an integrative approach, traditional psychotherapy, such as CBT, trauma-focused CBT, motivational interviewing, narrative therapy, and emerging practices such as art therapy. And as I said before, am in the process of training in neurofeedback eclectically to use. I also have created what I call the GRAPH approach that is rooted and grounded upon treating individuals with dignity, treating them humanly, and significantly from a person-centered and encouraging approach. I'm also currently seeking, as I said before, more training and certification in neurofeedback to further support veterans experiencing combat-related PTSD. What do I mean by the GRAPH model? Basically, I spell out GRAPH by first, G is for gratitude, helping vets learn how to focus and appreciate in the midst of their experiences, what is still worth having a sense of thankfulness for. The R is for resilience. It has been proven that resilience and support helps people when it comes to dealing with trauma. A is for adaptation, helping the person learn and realize what they can change, what they can control as it relates to themselves, the trauma of being in combat, and also in the environment in which they are returning back to. Also, F is for forgiveness. When people experience trauma, a lot of times forgiveness is very important. Sometimes that forgiveness must be extended to themselves, others, and life itself as it relates to the traumatic event. T is for tenacity. It's about cultivating and developing a spirit of endurance when it comes to trauma. Basically, GRAF is used along, as I said before, with traditional and emerging practices collectively to meet the individual where they are based on what is important to and for them from a person-centered approach. GRAF is also about addressing through counseling, compassion, and skill building support for vets, particularly vets who have been in combat. Therapeutic change in combat related PTSD. At the end of the day, what's most important will not be the technique. It will not be the evidence-based practice or emergent practice. The most important things, according to research, particularly Lambert in 2013, is the strengths of the individual vet and their supports. Also, the second most important thing, which is what I definitely try to pay attention to in practice, is building a rapport or therapeutic relationship. If you notice an individual's strengths and the therapeutic relationship or building connection makes up 70% of therapeutic change. The other two, 15% towards interventions, and the other 15% towards whether or not a person hopes that you can help them, is only 30%. So the key takeaway is the most important thing is the individual vet's strengths, supports, and resilience, and how you treat them or how you connect with them that matters the most. Emergent practices and combat-related PTSD. Neurofeedback is considered an emergent practice that treats and addresses trauma. Neurofeedback is used to treat in past symptoms of depression, anxiety, and affective disorders. It's also considered an alternative medication. Neurofeedback is the process of reviewing electroencephalographic frequencies to identify any dysregulation of the veteran's central nervous system that contributes to psychopathologies. Now, when we talk about the central nervous system of the individual, when it comes to neurofeedback, the focus is on looking at the activity of the sympathetic nervous system piece. That's where the amygdala is very active. So the whole idea is to create a sense of awareness and consciousness of how active the sympathetic nervous system side of the person is. The more heightened and aroused and hyped or on guard the person is, the higher activity in the amygdala, and also the higher the activity is in the sympathetic nervous system. Neurofeedback continued. Combat-related PTSD treatment requires approaching the physiological aspects and teaching warfighters or people in combat to gain control over their neurological reaction, the physiological arousal, and emotional response associated with their condition. Prolonged activation in a hypervigilant state leads to a maladaptive pattern of function in both the autonomic and central nervous systems, which work simultaneously. So basically, as I said before, when a person that has been involved in combat comes back home, they are still operating from that same mentality of hypervigilance, hyperarousal. And so neurofeedback is used to help them to differentiate that they are no longer in the war zone and that it is okay to operate it from the parasympathetic nervous system, which is about relaxing, facing the situation with calm, breaking the situation down and digesting it versus freezing, flight, or fighting. Neurofeedback is about advances in technology that allow practitioners to view brainwave patterns and further explore the central nervous system. So basically, this is where the practitioner gets to look at the activity from the sympathetic nervous system and also the parasympathetic nervous system for activity. Neurofeedback is about training that allows warfighters or people in combat to gain control over their neurological responses, their arousals, and emotional reactions as a result of combat. Neurofeedback is about allowing people in combat to learn how to relate their PTSD, to manipulate their brain's electrical activity to correspond with the chemical activity. So basically, it increases an awareness of where they're acting from. It allows them to understand whether or not they're acting from their sympathetic nervous system, which is a fight, flight, or freeze perspective, or giving them the option to also make the choice to operate from the parasympathetic nervous system. Other things about neurofeedback, vets are educated on their condition and taught techniques to control and change their physiological responses to combat related to PTSD. So here, vets who have been in combat are taught how to operate more from their parasympathetic through awareness. Neurofeedback is about typically used in conjunction with counseling. Counseling interventions positively impact the central autonomic nervous system, creating changes in brain activity and in physiological responses. So neurofeedback is designed to be connected to other areas of treatment and supports eclectically. Neurofeedback training. As I said before, I'm in the process of trying to gain more training and certification in the area of neurofeedback. Basically, I want to gain the certificate and training as a way to work with vets who have been in combat, who also have been diagnosed with PTSD. In order to do this, I must first obtain neurofeedback training and also certificate from the Biofeedback Certificate International Alliance organization. Basically, I will become educated on specifics of electrical activity of central nervous system and also gain information on how firing patterns correspond to functionality and behaviors within the brain. Other things about neurofeedback training, as a counselor or clinician, I will gain along with other people who are interested and decide to take training and become certified, will gain knowledge about the history of the field, principles of human learning, also applications of neurofeedback, and understanding of neuroanatomy and understanding of instrumentation. Also, you become trained in psychopharmacological considerations and also neurofeedback treatment. Another emerging practice when it comes to working with individuals that have experienced combat-related PTSD is art therapy. Art therapy has been used with treatment of veterans dating back to the 1940s. Basically, it was started by Mary Houghton, the person who helped shape the field of art therapy. She basically used art therapy to treat the veterans and help them to make meaning of their trauma. Art therapy is an integrative mental health and human service profession that enriches the lives of individuals, families, and communities through active art making, creative process, applied psychological theory, and human experience with a psychotherapeutic relationship. Here, research shows traumatic memories can be stored in a person's memory and can be remembered through recollections of storytelling, recalling sensory, affective, visual, auditory, and kinesthetic activities. This happens through art therapy. So allowing the person to express themselves through art allows them to create space between the trauma and themselves, and in turn helps them to make more meaning or new meaning that's more intentional, and it helps them to release emotions that they may have kept inside. Art therapy and combat-related PTSD. Art therapy is used to highlight nonverbal aspects of trauma experiences through use of art and involvement with creativity. Art therapy is known for processing traumatic experiences by providing a bridge for unspoken memories to be linked to memories disassociated with memories to make new meaning of the events. Oftentimes, what I'll do is have a person draw something and express something that connects to an experienced trauma. And what it allows them to do is it allows them to put themselves more in a space that allows them to be creative while also expressing. And it also calls for metaphors and it allows them to make meaning that puts the situation more from an objective point of view that creates an opportunity for them to further release past emotions that were negatively or cognitively negatively associated with trauma. Other things about art therapy and combat-related PTSD. The parts of art therapy includes the following: processing of traumatic memories, the process of symbolization, integration, containment, transference, and countertransference. Art therapy and combat-related PTSD is about therapy that allows action therapy. It combines movement, tactility, vision, memory, imagery in the creative process, and it also allows for nonverbal pieces of traumatic memories to be exposed. Art therapy also offers a way to provide active activity in the neural and sensory processing pathways to create holistic healing. Art therapy also is about letting veterans address traumatic memories of combat using symbols, which make a collage of experiences by using art to represent emotions and reactions to trauma of the individual that communicates a message. So, like I said before, I will often do is have individuals draw pictures that may represent their sense of what it means for their trauma, or what does the event represents for them when it comes to life, what does it represents when it comes to them as an individual. And this is definitely part of the healing process because it allows them to see what they've been internalizing for so long, to see it on paper. Art therapy involves bilateral stimulation of the brain, where engagement, integration, and planning functions of the prefrontal cortex to sequence narratives using left brain functions occur. When this happens, the left and right hemispheres of the brain is enabled to process and store traumatic experiences in long-term memory. So in this process of art therapy, the right and the left brain, the right and the left side of the brain are allowed to operate simultaneously, which creates more meaningful opportunity and a chance to have a fuller expression of. Art therapy allows an outlet for externalizing and creating emotional distance, as I said before, through the use of paintbrushes, markers, crayons, pencils, and other art supplies that serve as mediators between the person and traumatic image. Art therapy is also about creating a safe space for the individual vet that has had experiences with combat to distance themselves from the traumatic experience and to also view it from a distance, or what I call outside looking in, or having them look at it in a way that helps them to depict the trauma experiences and also to view the finished image at a physical distance. So what it allows, art therapy creates a space where a person can pull out the emotions from within and the traumatic event, put it on paper, put it in art form, and put it in a metaphorical state that allows them to see it, and to not just see it or feel it, but to see it and feel it differently, to have a sense of opportunity to be resilient, or also to have an opportunity to make new meaning, or to be strengthened as a result of the experiences, and also as a way to develop a sense of courage and an opportunity to help someone else along the way that might experience similar trauma, if not the same trauma. Art therapy can be helpful when the person doesn't remember the events and trauma narratives. It also helps the person to feel safe while recounting and reprocessing trauma through drawing and visualization. Basically, art therapy is so powerful and pivotal because it uses more of a a metaphor or an objective space where the person can feel more free as opposed to just directly talking or referring to themselves or not having that sense of space from the trauma and themselves. Art therapy is mostly used or practiced for PTSD in the creation of a visual trauma narrative, whereas traditional narrative therapy uses storytelling through writing or verbally expressing the story of trauma. Art therapy uses pictures and drawings, as I said before, other means of art to communicate trauma or the narrative or the story of trauma. This narrative can provide a space for recounting and reprocessing as the veteran learns how to deconstruct and reconstruct the narratives in their heads relating to themselves, others, and the world that's no longer maladaptive, but helps to be adaptive in a sense of resilience, a sense of courage instead of a sense of fear or a sense of lack of control. Art therapy is a visual trauma narrative, and it's important because this type of therapy provides emotion-related memories and emotions uh, to be connected to a trauma. But this only happens once the person learns to feel safe as a result of the environment developed by the therapist. Christian view of dealing with trauma. Spirituality can be a protective factor for veterans involved in combat and after. Veterans with a strong sense of faith and spirituality may turn to their higher power following a traumatic event to help them cope, make meaning, and manage past traumatic events in an adaptive manner, or could also question it. Helping veterans to put their faith to the test of trauma may include overcoming beliefs in the face of trauma, loss of faith, negative spiritual coping, feelings of guilt, and lack of forgiveness, while learning to also believe in the love of God again. A Christian view of dealing with trauma is also important because it empowers veterans to learn how to discover God's love and become strengthened within the process. It also helps individuals move from ruminating on negative associations with trauma to learning how to release them. Other things. There are 3 interventions that have been best used to support veterans who have experienced or are experiencing spiritual distress due to traumatic events. One particular intervention is adaptive disclosure, a therapeutic method targeted for active duty service members that focuses on processing the morally or spiritually injurious event without shame or guilt, particularly when it comes to trauma. Another intervention is building spiritual strength, which is an 8-session group-based treatment intervention that focuses upon addressing spiritual conflicts that have occurred to develop greater spiritual resilience. The third intervention is the spirituality and trauma model. This focuses on targeting moral injury and spirituality for service members diagnosed with post-traumatic stress disorder within residential treatment settings. The purpose is to increase a sense of comfort in talking about the traumatic event and to increase healthy spirituality. Conclusion. The psychosocial and combat-related stresses for veterans before, during, and after war can weigh on the individual spiritually, mentally, emotionally, socially, and physically. The use of traditional psychotherapy is used currently to work with individuals who experience combat-related PTSD, but more emergent practices is necessary. Eclectically is the best approach in order to adapt, adjust, and accentuate the needs of veterans involved in combat that may have developed PTSD as a result. So these days, we're finding that emerging practices such as neurofeedback, yoga, also things like art therapy, EMDR, these are healthy practices. CPT, cognitive processing therapy, prolonged exposure therapy. These are things that are helping also along with traditional practices that were used in the past to deal with trauma. Other things. The stigma of being a veteran in the military and experiencing mental health needs such as PTSD can be discouraging from the reality of treatment and the need to ask for help. There is a need for encouraging, effective, and emerging integrated practices to help address combat-related PTSD. The most important factor when providing a treatment, however, is about building a healthy view or a faith-based view and developing a rapport of compassion and empathy while working with individuals, building up their strengths, supports, and resiliency. Thank you.